Next, I'm going to welcome Lauren Schrock. She's one of the new neurologists at the University of Minnesota, and she's going to talk about deep brain stimulation for blepharospasm. Are we there yet?
Thanks for inviting me, Dr. Harrison. Originally on the schedule, Dr. Paul Tuitt, who's my wonderful colleague, was going to be joining us, but he asked me if since I'm new, perhaps I can come and share about my area of expertise in relation to blepharospasm. So my area of focus is on neuromodulation, or actually invasive neuromodulation, so deep brain stimulation. So I'm going to give you some, we're going to take a look at blepharospasm from my field, all right? So this is going to be a little bit of bionic people talk, okay? So first of all, what is deep brain stimulation? So essentially, it's like a brain pacemaker. So a wire is implanted through a neurosurgery deep within the brain into roughly about this level for most disorders, and we stimulate from different contacts on that electrode, and we connect it underneath the skin to basically a pulse generator, so it looks like a pacemaker, but we can put it on either the right or the left. And we adjust the stimulation settings in clinic using a programmer and either communicating with that pulse generator with the old standard, it was through radio frequency, and now we have Bluetooth with iPad system that just became available. So a little bit of history of the development of deep brain stimulation was accidental, like a lot of things in medicine. Back in the 1940s and 50s, they were doing neurosurgeries and didn't have as much guidance, didn't have the imaging that we did, and a famous neurosurgeon, Dr. Cooper, accidentally cut an artery in a patient who had Parkinson's disease. Happened to be the artery that fed right into the globus pallidus interna, and all of a sudden, Parkinson's symptoms on that side of the body improved. So that was the beginning of doing neurosurgical procedures of lesions in the brain. Brought up the idea, an accident. Then, when neurosurgeons were trying to guide where they take out tumors, they want to make sure, for instance, they're not getting into the language part of the brain, that sort of stuff. What they do is they stimulate around the area that they're going to take out a tumor to make sure that they're not going to cause real problems when they take out that tumor, that tissue. And a famous neurosurgeon named Dr. Hessler recognized that stimulation mimicked exactly what people did when they did the lesions or burned out areas of the brain. So it was actually not many people have heard of Mundinger, but he in 1997 was the first person who thought of doing chronic stimulation in the brain for a movement disorder. The most famous person is Dr. Benabide in France, who in the 80s and 90s really started developing deep brain stimulation, or a chronic implanted system in the brain for tremor initially. So why would this ever work? So we do know a few things. We know that neurological diseases are associated with abnormal neuronal activity. So they're firing abnormally, not the way that a normal brain would fire. So the idea is that we can modulate the neuronal activity to improve symptoms. The thing is, we don't know how it works. We know it works, but we don't know how it works right now. So one of the reasons I came here to the University of Minnesota is because we have one of the top neuromodulation centers and groups in the country, and we're really looking at that. How does this actually work? And when we start to understand it better, we're going to be able to optimize the therapy even more. So this is a drawing of the components of a system. So you've got, do we have a pointer? So what you've got, the main parts, you have this pulse generator. This goes in the chest, underneath the skin there, and that has the battery and sends out the stimulation, okay? And so we can program it. It actually has a computer chip in there. You can save all these different programs. It's actually getting fancier and fancier. Whether that leads to improvement, we'll see, but the companies like to have us believe so. So then you have a lead extender, so it comes out of the, so we'll start in the brain. So this is deep in the brain. So this, each one of these little contacts is 1.5 millimeters, and it's less than a 1 millimeter wide. So that goes deep down in the brain, and it's connected through a wire, comes out of the skull, but underneath the skin, and the wire goes underneath the skin, down the neck, and connects to the pulse generator. So those are the different parts. So what does the surgical procedure involve? One thing, and this is changing over time, but traditionally it's an awake surgery, all right? So that's why I show you here. We have people activating and involved during the surgery. And the reason why is because to verify where we are in the brain. So first of all, before the surgery, we target within the brain. We get really special fine-cut MRIs, and we decide, so this is one that we planned recently to go in what they call the globus pallidus interna here, and these are different views of the brain. And what this computer does, the neurosurgeons used to have to know trigonometry. They don't have to know that anymore because these computers calculate it for them. So for stereotactic and figuring out where it goes in the brain, this we've targeted on here, and then it spits out these numbers that we put in on the frame, and that goes in. But back in the old days when it was developed, they'd actually pull out the trig and figure it all out. So in order to determine where we're going to go, so these nucleuses that we want to get to, maybe 3 millimeters by 6 millimeters by 10 millimeters. The globus pallidus is about 4 millimeters by 10 millimeters or so. So they're very small, and that contains motor areas, emotional areas, thinking areas, and we need to make sure we're in the motor area. So that's one thing I'm involved in the surgeries. I'm trained in the neurophysiology, so I know how to listen to neurons in the brain and know where we are, okay? So, for example, as you're going down, this is an example, we put a wire down and an electrode, and we listen to the neurons, and we know that neurons in this area in the GPE, or globus pallidus externa, sound a certain way, and then we get here into the target area, they sound a different way. So this is what you might hear when you're in surgery and awake. Let's see here. So that's typical. This is from a Parkinson patient. So this is the globus pallidus interna cell. And what I'll do is an exam during it, and you can hear when I'm in the arm territory, I can hear it go speed up its firing, for example, or in the wrist territory. And so we need to make sure we're in the motor territory when we do this. Because 1 to 2 millimeters off, and we can run into trouble. And this is, so, oops, sorry. So here's an example. You don't have to, I have a lot of complicated figures. I'm kind of giving you an overview. The idea is that this is complicated. So these are views cutting, this is a view of the brain from like slicing it like this. This is a view of the brain slicing it like this. And this is a view of the brain slicing it like this. So if you put a lead in this area, the issue is you have lots of other structures around it. So if you got it in the wrong area, for example, if you put it, rather than, our goal area is right here, kind of where the red is, in the middle of the red and the blue. If we go a little bit too off medially, they call it, toward the center of the brain, will cause muscular contractions and slurred speech. If we go too deep, we stimulate the optic tract and people will see flashing lights and that sort of thing. And actually, in the operating room, we listen to the optic tract. We turn off the lights. We just did this yesterday in the case. So with every GPI case, at the bottom, usually, depending on where the targeting is, the optic tract is right below the base of our target. So what we'll do, we'll put the electrode down there. We turn off the lights in the operating room, and then I shine a bright light in the patient's eye, and you can hear it. You can hear it really distant, but you can hear the firing through the optic nerve. So there's pretty cool stuff that goes along with this, and you really have to know your anatomy, and it makes a big difference. So the other thing is, The deep brain stimulation is very patient specific. So we make all our decisions based on knowing who you are, what's going on with you. For example, if you're a really thin person and you don't have a lot of room up here, we might want to put a battery down here in the abdomen, okay? Or depending on what disease you have, you might want to put the target, the stimulator in a different area. In the clinic, another thing that I do afterwards, I have to figure out where to stimulate and what shape to stimulate and figure it out so it fits with your brain. And I have different ways I can do that. I have the stimulation pulse that's happening, but then I can change the configuration so I can change the shapes depending on how I activate the different contacts. Because you saw those funny shapes that we had before. They're not just circles. I have to shape things to fit in there sometimes depending on where it is. So I have to know my physics to properly treat you. And my electricity. My husband tells me I'm an electrician. So what is DBS approved for? So it's actually, people don't realize this, but this is approved to treat tremor. The FDA approved it in 1997. It was approved for Parkinson's disease to treat the motor symptoms of Parkinson's in 2002. For dystonia, and this is why I'm talking about it today, is because blepharospasm is a type of dystonia. It was approved in 2003 under what they call a humanitarian device exemption. In the case of dystonia, it means that there weren't enough people to show the statistical effect or benefit that the FDA usually demands, but it looks like it's effective and it's likely not harmful, so they gave it a pass. Basically what it means is that we have to it has to be done under an IRB, or an internal review board has to monitor the patients who have it done. It's also available for obsessive compulsive disorder under a humanitarian device exemption too. But then that, you blast the entire front of the brain and it burns out batteries like crazy. And that's just early in our understanding. For seizures, it's available in Europe and Canada, and there's a special closed loop but surface stimulation one available in the US for seizures. So what's available in the US right now? So since 1997, we've had this one, and so here's the battery pack, here's the leads, and they have 4 different contacts on them. So they stimulate out in a circular, spherical direction, and here it looks like an old TI-81 if anyone was back in those days. And you hold this over where the battery is, and then you can change the programming. All right, so that's still available, and that's the most commonly used one still. However, within the last year, St. Jude came out with a new device that we are becoming more and more familiar with. I'd say our program is one of the most familiar in the country with this now. What's neat about it is it has directional. So you see, rather than just 1, 2, 3, 4, you can direct it in one of 3 directions here. From the middle 2. So there's 1 electrode here, 3 here. So if I turn this one on here, it goes out this way. So here's an example of this in practice. So here's the typical one where you have it around. Here, you can push it in one direction. And the idea is that what we can do is reduce the amount of likelihood of side effects and that sort of thing. And this one they're pretty excited about. It's iPad. This is my programmer, is an actual iPad, and then you get an iPod as the patient. So it's kind of wild. This is the remote control for the thing. So this is a little bit, this is just talking about dystonia. So with tremors, when you turn on the DBS, it goes away right away. With Parkinson's symptoms, in general, it goes away right away. The tricky thing, and why not many centers do DBS for dystonia, is rather than in seconds to minutes, the dystonia takes maybe days to weeks. For what you do in clinic, you don't see the effects of for at least days to weeks. So it becomes complicated. So surgery dystonia, again, started as lesions, as I said. Here's a child with dystonia who had a lesion here done, and it was effective treatment. So deep brain stimulation, again, has been approved since 2003 for several different types of drug-refractory primary dystonia. Generalized, segmental, which Mays syndrome is a segmental dystonia, hemidystonia, and cervical dystonia. Why it's an advance over the lesion therapy is that it's not destructive, aside from a few cell layers around where it's placed. It's reversible, it's adjustable, and it can be performed safely bilaterally, whereas that was not the case with the lesions. So when do we consider it? It's only when it's clear that you have the right diagnosis. You can't treat it with non-invasive treatments, and that includes Botox has been appropriately administered by expert injectors. You want to have significant disability, so there's really a reason for it. And in the case of generalized dystonia, you want to get it earlier is better, before you get contractures or your arms get stuck in a certain position or legs, that sort of thing. So the other thing is rule out treatment, dystonias that can be treated with medicines. So the most well-known DBS treatment for dystonia, so here's a patient with what they call D1T1 dystonia. He's 15, or 14 or 15 here, and see he has spasms that are involving his trunk into the leg. The shoulder goes as well. You can see his hands will posture.
Yeah, we have a little bit
as well.
Inversion on the left.
And then I'll show you an example of, and this is why we're thinking about it for other types of dystonia. So this is about 6 months after he had deep brain stimulation placed on the right. And essentially the only thing that was remaining was a tiny little bit of slowness and cramping in of the thumb. But he had pulled out of school because of embarrassment and was very depressed prior to, very shy kiddo, and he's back at work, back at school now, enrolled, and he says it's really given him a new lease on life. So this is why we get excited about this, this treatment, is because of these dramatic effects that you can have. Yeah. The interesting story about him is we actually had it free. He was someone who couldn't get it because he didn't have insurance. So I worked for a year and a half to get everything donated for him. So, so this is looking at the evidence for the efficacy of deep brain stimulation in dystonia. So you look at the generalized dystonia, what I just showed you. The DYT1 is here, 80% improvement, for example, does very well. It has a big black line, which means there's really good randomized controlled trials that show that. Then you look at cervical dystonia. We actually have good evidence now. It's not as dramatically improved in the motor component, but in pain and disability, it's often significantly improved. Here's cranial dystonia. We don't have specifically blepharospasm, but MAGE. So in the larger trials, it shows maybe 60 to 80%. This is before they did a recent randomized trial that shows more like 40 to 50% improvement. But it does look hopeful. So in generalized dystonia, I'm going to kind of skip over this actually. This is just showing that here's this is how severe it was initially and at 3 months. One thing you'll notice, there's a trend toward further improvement as time goes on, even though the same settings are on. And that suggests that there's a plastic change in the brain. It's not just treating the symptom, but it's changing the brain wiring and network. And we see that with all types of dystonia. This was another one. This was a sham controlled where they actually implanted it into all people, but the first 3 months, half of the people had the DBS turned off and it was not on, but they weren't told. So this shows that the people with the sham only had 5% improvement and 40% improvement in the stimulation group. Here is another patient of mine. This is to show cervical dystonia, but she actually has MAGE.
And then why don't you go ahead and turn it off?
She's already had it 2 years, and we haven't turned it off yet. She's coming in.
Close your eyes for a minute before she does it, while she logs in, and count backwards in your head by 7.
Well, it takes a delayed effect to turn it on to have the effect. When you turn it off, in a lot of cases, it comes back immediately.
Are you already turned off? Yeah.
So
you did. Okay, so never mind.
And she's kind of shocked.
Oh, yeah.
It's coming back so quickly, and you can see that pulling the cervical dystonia.
Wow,
she has
immediate.
Blepharospasm. She has
Is it
oral
not?
mandibular as well.
Okay, just about.
And so what's
15
neat
more
about her
seconds and then
story is
we'll-
she came in to me and she had a little boy who was adopted, and she couldn't have her own children because she couldn't get off dystonia medicines.
Yeah.
And she, at 6 months post-op, she came in pregnant. So that was a pretty cool outcome for her. So for cervical dystonia, again, there's about 129 reported cases. Most are small, individual case reports are small series, but more recently, there's been a well-designed study of 10 patients where they reported 44% improvement in the motor score of the standard scale we use for it, 64% in disability, and 65% in pain. And pain is a major component to that cervical dystonia. So more recently, we had a randomized sham-controlled trial, and again, this shows improvement you see with cervical dystonia. So again, that's where we are. So for blepharospasm, what's the evidence? So we have a single case report just in 2016 for isolated blepharospasm. So this was just a 52-year-old man who had medically intractable blepharospasm. He had 88% improvement of the eye spasms at 15 months, so not a lot of information, but that's hopeful, I suppose. But the important thing is, so where do I enter into seeing people with blepharospasm who might be considering more advanced therapies? It's people with Mays syndrome, and as Dr. McClellan said, 50% of people with blepharospasm spread to contiguous muscles, so oromandibular, cervical, laryngeal, with earlier the highest risk. So here's a man with Mays syndrome, a patient of mine, and here you go. So he is a principal at a school, and so it's very, very disabling for him. Every time it would bring it on more whenever he tried to talk to anyone, his eyes would be closed, it's very uncomfortable, he'd be very fatigued from it. And so he had multiple attempts at Botox from a couple different ophthalmologists, a couple different movement disorder specialists. We tried all the medications without effect. So we went ahead and did go forward, and here's him about 6 months. I have a 6-month and 1 year out from deep brain stimulation. And so, it looks perfect, but it's actually not perfect. He still struggles with fatigue. He still feels like he has to work a little hard to keep his eyes open, but he can keep them open all the time. He's still, he's happy about it, but not extremely overjoyed as you'd expect with it. So that's one thing we have to realize. There are other parts, some non-motor things associated with it. And this is about a year out from the deep brain stimulation. So, he looks very good. You wouldn't be able to tell on the street, but he still feels a sense when he gets more tired. There are times in a day when he doesn't feel it at all. He hurt this wasn't caused by DBS, that he had a shoulder cuff injury. Okay, so almost done. So again, this is just showing that you don't have to read all this to say that there have been quite a few cases for Mays syndrome, usually just 1 or 2 cases, 61 reported cases, variable improvement, 40 to 80% when you take them all together, and some people are non-responders, and we don't know why when they aren't responders. In a meta-analysis in 2010, it said average was about 66%. So this is looking just at the long-term outcome in a study of 12 people with Mays syndrome. And if you look specifically at the blepharospasm scale, it had 25% and 38% improvement over time, first and last follow-up. The I score of the Burke-Farr and Marsden had 38% and 48% improvement. So it's not perfect at all, but it improves things. One more video, because videos say more than those slides. So this is another person who had Mays syndrome. She had prominent involvement of the parapharyngeal muscles and laryngeal muscles as well. So when I first met her, we could barely understand her because she had so many pauses in her speech from it. So we have just turned off the DBS here temporarily, and you can see she pull, and she can't even turn her head to the other side, and then we turn it back on, and she's had improvement. But, a couple more and we'll finish up. One issue we found is when you modulate the motor system of the brain, you might notice effects in other areas potentially. Now, there has been shown no effects on cognitive effect looking longer term, 1 year, 3 years, when you follow it neuropsychological testing. But a group at UCSF noted that in these patients who had formerly normal working arms and limbs who underwent deep brain stimulation in the globus pallidus interna, they started to notice these subtle things. They wouldn't take it back. They had were happy with their dystonia, but They just had little difficulty lifting things up the ground. Handwriting was more messy and smaller. Had a little difficulty walking, particularly walking upstairs, getting up from the chair in and out of the car. And if you look closer at their examination, they have subtle slowness.
Cervical dystonia is evaluated preoperatively. On exam, he has prominent blepharospasm, oromandibular dystonia, anterocollis, and laterocollis. The rest of his neurologic exam was normal, except for some mild truncal dystonia. 3 years following bilateral GPI DBS, stimulated chronically at 185 Hz, the patient demonstrated continued improvement in his dystonia. However, he complained of decreased facial expression and generalized slowing. On exam, he has slowed rapid alternating movements, as well as slowed and decreased amplitude of finger tapping. He also complained of gait difficulties, and on exam showed some difficulty with turns. As well as a short stride while jogging, and difficulty with walking backwards. After a few minutes following reduction in his DBS frequency to 60 Hz, the patient no longer looks as bradykinetic. There is improvement in his hand movements and finger tapping, as well as improved gait with less difficulty turning, and improved jogging with a greater stride length, as well as less difficulty walking backwards.
So this brings me to my final two slides, where groups have seeing these side effects with that target thought, well, knowing what we know about the brain circuit, the basal ganglia circuit, could we consider a different area of stimulation? And so a trial went forward with subthalamic nucleus stimulation in isolated dystonia. This is recent outcome, 3-year outcomes of that. 20 patients. Again, they showed similar, if not more, but this, again, this is not a controlled trial, improvement in the dystonia, but they developed a novel stimulation effect on this side, on the opposite end of things, where the extra wiggly movements, like the dyskinesias that you see in Parkinson's disease. However, those can be programmed out without losing effect. So final summary, so DBS for blepharospasm. Again, little data to for the treatment of isolated blepharospasm, a single case. But there is developing evidence for DBS for Mage syndrome that suggests potential benefit for blepharospasm, but responses do vary. We do need prospective controlled clinical trials with targeted blepharospasm targeted outcome measures. And things we're going to be looking at in the future are what stimulation target is appropriate, looking at the somatotopy, or in the area within the nucleus. Is there an eye area where we need to focus on within the basal ganglia? And do we need to look into comparative treatments of DBS and standard, more aggressive ophthalmology surgeries? So thank you. This is my team in neurology. And we do have research ongoing if anyone's ever interested in getting involved. We were just named Udall Center of Excellence in Parkinson's Research, specifically in neuromodulation, and that's what brought me here. So thank you. Sorry for running over.